topic in anatomy, and that is the abdomen, right? Abdomen. So we'll start with the topic of abdomen, and the topics which we'll be covering in abdomen will be the basic conceptual topics that are going to help you in your all the exams, including universities and other even PG entrance exams as well, because they are going to be highly conceptual. Okay, so let's start. So these are the exam mastery live classes, as you can see over here. Plus, we can also understand that we have this volatile topics quick revision as is written over here. And apart from that, we have high topics for all the subjects. Just a second. Okay. Let me just check. Okay, yeah, now it's working. So sorry for the interruption, a bit of technical nag over here. So as we were discussing that abdomen is what we are going to start, and this is an exam master live classes. Some core features of Auricle is what we can see over here from live classes. As you are seeing, we also have recorded classes, notes, MCQs. The three basic plans, we discuss them daily, can basic standard mentorship, ranging from 15 to 50K. The duration is different. One is for 3 months, other is for the whole year. And you can also book a slot for your personalized counseling session as well, right? Okay, now let's come to the topic as we're discussing the abdomen. So let us start with the abdomen part over here. Okay. So let's come to the main topic. So abdominal cavity and peritoneum. This is what we are going to discuss in this 1 hour fruitful, and I hope it is quite a engaging session as well, in which we all will be discussing very important concepts. So first question, explain about the anatomy of the abdominal cavity and peritoneum over here. So we have to understand few things over here, that what is abdomen and what is peritoneum. First of all, the basics of it. Okay, let us understand the basics of it. See, in a very simple words, I will start with, if you look at the trunk, if you look at the whole trunk over here, suppose these are the shoulders, okay, and this is the trunk part going down. Now this, imagine the whole trunk. And here in the trunk, we all know that we have this diaphragm over here, right? Suppose this is the D for diaphragm. Then we have to understand that below diaphragm, whatever is there is the main abdomen or abdominal cavity is below the diaphragm. And diaphragm is not a straight muscular tube, it is a curved, J-shaped curve. Above diaphragm, we have this TH dot, that is thorax over here. Now, as you go down in the abdomen itself, the lower part of abdomen, we have this area known as pelvis. That is also read along with the abdomen. Okay. The abdomen and the pelvis, they are commonly read along with. And below pelvis, the last part we have is the perineum, the lowermost part where we have the openings of the bladder or the anal canal, all that. So we have the abdomen over here, right? And below abdomen, we have the pelvis, and below pelvis, we have the perineum. This is the area abdomen. Now, below all of this, obviously, we have the lower limbs, which are a totally different area of the body. Now, this is the abdominal cavity, we all know, and it is quite flexible. Why? Because with each breathing, our diaphragm is going to go up and down. So a dynamic area, we can say, is the abdominal cavity. Now, second point is that what is there in the abdominal cavity? It is a huge area. We all know it has the gut, which does the peristalsis, and which is, if you all know, the food goes through the intestine, gets absorbed, and the stool is formed, the stool is passed out. Apart from the gut, we have the organs like, say, liver, then we have the pancreas, then we have the gallbladder, then we have the kidneys. All these structures are also placed along with the gut. Okay, though we all know that liver, pancreas, gallbladder, they are directly related to the gut, because all their secretions are poured where? Are poured into the gut tube, right? The duodenum. Kidneys. Kidneys are also present in the abdomen, but we have to understand that kidneys function-wise, kidney, or we can take example of spleen as well. Function-wise, they are not directly related to the gut. Kidney, we all know what's the function of it: formation of urine and other homeostasis in the body. Spleen has different functions like sequestration of the old RBCs. It has a lymphocytic function. But these organs are also present inside the abdominal cavity. So we have kidney, spleen, we have adrenal glands, along with kidney, we have the ureter and all that. So they are present in the abdominal cavity, but they are not directly related to the gut per se. The liver, pancreas, they are directly related to the gut. Way to understand. So this is abdomen, a whole, and then we have few organs. I'm just giving you a brief idea. Now this is abdomen. We all must be aware of it. I'm just giving you a different way to look at the same thing. The second question comes is as a topic was our question was peritoneum. So what is peritoneum? What is peritoneum over here? Now, in the thorax, we have gone through structures like the heart and the lungs. That heart and the lungs were covered by a double layered fold of the serous membrane fold, which are known as the pleura and the pericardium. Similarly, in the abdomen, we have peritoneum. So it covers what? It covers mainly the regions of the gut. It covers mainly the regions of the gut. Now, the point is, why does it cover? Okay. Now, heart is moving, right? 70 to 100 beats per minute. Lungs are moving all the time. Similarly, gut is also moving. You eat anything, and the peristalsis happens for so many hours. Obviously, gut is moving. So it needs a smooth, flexible area. Second thing is for the passage of vessels, nerves, and lymphatics, all of that. We have peritoneum. We'll see it in detail. What I'm trying to tell you in a broad nutshell, or you can say a bird's eye view, is that the abdominal cavity has mainly gut and related organs, plus it has some other organs. And most of these organs are covered in one way or the other, or they are related in one way or the other to the peritoneum. Okay, here also it will have two layers, like it had in heart or lungs, like a parietal and the visceral layer. Parietal will be close to the body wall, and the visceral will be close to the viscera. Okay, that is the whole point. Now, if you have gone to this much basic understanding, then we can go to the specific areas what we are going to discuss. So, explain about the anatomy of the abdominal cavity in peritoneum was the question. Abdominal cavity is the largest cavity which encloses the peritoneal cavity between its parietal and visceral layers. Fair enough. This is how you have to write the answers. Limited movements for proper functioning of the gut in particular and body in general, the basic functions. Now, one applied aspect also they have given that infections involving the parietal peritoneum impart protective board-like rigidity to the abdominal wall. And below that, they're saying the referred pain from the viscera to a distant areas due to somatic and sympathetic nerves reaching the same spinal segment. Now, see, once you hear this for the first time, you're like, okay, what they're discussing, I'm not able to understand, right? Who can even tell in simpler words? So simpler word over here is basically what they're telling over here is the applied aspect. I'll give you examples. We have discussed parietal and visceral in a lot of other lectures as well. We all should be knowing that this peritoneum or pleura or pericardium has two layers. Okay, one layer is lying outside, that is close to the body wall. That is what we call as parietal layer. So that is the parietal layer. Okay, and one layer is lying inside, which is adhered to the viscera. That will be the visceral layer. So this red color, imagine it to be the visceral layer. Okay, the space between these two. So there's very less space, but that is, imagine is filled with the simple film of fluid. That is the peritoneal cavity or a peritoneal fluid over here. So this yellow color, understand this. Now the point over here is that this parietal, which is close to the body wall. So here you have the body wall. Body wall is innervated by which nerves? Somatic nerves. And the viscera is related to the visceral layer is related to the viscera. And this viscera is innervated by the autonomic nerves. Autonomic. So therefore, though parietal and visceral layer are very close to each other, but their functioning or their sensitivity is totally different. The parietal layer on the one hand will be pain sensitive. Why? Because our body wall, like our skin over here, is pain sensitive. The visceral layer on the other hand is pain insensitive. It is pain insensitive. Okay. Therefore, what the applied part they started to write over here, that infections involving the parietal peritoneum impart protective board-like rigidity to the abdominal wall. Suppose there is any infection to the wall, then how will the wall present? How will the wall will go into spasm and rigidity? Okay. The moment any part of a body is injured, that part wants to remain a bit of this in an immobile fashion. Okay, don't disturb it because I am in a repair mode. Same thing happens in a parietal peritoneum. Other thing which they are saying is commonly what we feel in our day-to-day life, that referred pain from viscera to distant areas due to somatic and sympathetic nerves reaching the same spine segment. This is very important applied aspect discussing in the beginning only. See what happens is, suppose you went outside to a party or to a marriage or to any function, you had some food here and there. Suppose the food was stale, food was not fresh. What will happen is, suppose next day you develop a stomach ache and diarrhea and all that, right? That is known as gastroenteritis. Now, where do you feel the pain? You feel the pain around the umbilicus normally. Okay, around the umbilicus. Disease is what we call it as gastroenteritis. This is what we call it as gastroenteritis. So what happens is these are referred pain. The pain is not the infection is not sitting deep to the umbilicus. Infection is inside this small intestine or the midgut hole, but the referred pain goes to around the umbilicus. Same thing happens. You must have heard a lot of cases of children suffering or teenagers suffering from appendicitis. That's quite common. Pan, not just India, but pan world. Appendicitis present on the right side or right lower quadrant of the abdominal cavity, right? But where is the pain felt initially? Pain is felt initially again around the umbilicus. That is the referred pain part. Similarly, you will see a lot of things which are going to be practically very useful. So let me tell you, no matter which stream of science you pick up in your PG or which practice you do after doing MBBS, once you sit in an OPD, either in hospital or your own private clinic, pain abdomen is one of the most common symptoms and signs which a patient is going to come to you on a regular day-to-day basis, right? So this thing you should know which areas in which all that we'll discuss later. Pain abdomen is such a huge term, such a big broader term. A lot of patients are going to come to you with that issue. Okay, fair enough. Let's move down. 9 regions of the abdomen. This is what I was going to discuss with you, right? Just give me a second. Okay. So yes, you're discussing these 9 regions of the abdomen. We'll just see. I hope all of you have must played the games like tic-tac-toe. Oh, it's tic-tac, no? Something like this. Where we make this crosses and circles, and whoever makes this 3 in sequence will win the game. Right? So it is like that. So abdominal is divided into 9 regions by 4 imaginary planes, 2 horizontal and 2 vertical, like 2 horizontal like this and 2 vertical like this. So we have horizontal planes. You'll see that what are those known as horizontal planes. We have the transpyloric and transtubercular. Many times in place of transpyloric, we also can take these subcostal planes as well. We'll see. And these are important. These are very, very important actually. Vertical planes, these vertical planes mainly go from mid-clavicular region to mid-inguinal region, to mid-inguinal point over here, lower down. Okay, so you'll see, I mean, you can go through all of that, but best is to look at the image over here and try to understand from here. This is the best way we can understand this. So see, we have these 2 vertical planes. They are going from mid-clavicular region, both the side, and below they are going to mid-inguinal region, right? From mid-clavicular to mid-inguinal. These are the 2 vertical planes. Now, horizontal planes, as I said, that we can take 2 planes. Remind you, all of these are very important. We have the subcostal plane over here. Okay. The word itself is self-explanatory. Subcostal means below the costal cartilages. And in thorax, we learned in the lecture on the thoracic cage that there is this costal margin over here, and the lower point over here, which rib lies at the lowermost point. We have the 10th rib over here. So why not 11th or 12th? Because 11th and 12th were the floating ribs. So at the lower subcostal plane, we have the 10th rib, right? And at that, if you make a horizontal plane, you have the vertebral level of around L3. But initially, we saw another plane that was known as the transpyloric plane. Transpyloric plane or transpyloric plane of Addison. It passes through the lower border of L1. So it is placed where it is at the tip of the 9th costal cartilage or the tip of the 9th rib. So you can imagine that if you take a plane from here, like this will be our transpyloric plane, which is actually quite important. We'll discuss it in detail, right? So we have this 2 horizontal planes, transpyloric, or can also take subcostal plane. And below you have this intertubercular or the transtubercular plane that passes through the L5 vertebrae. What is this tubercle? It is actually 4 to 5 centimeter behind the anterior superior iliac spine. The spine over here. So this this tubercle. We have this around 4 to 5 centimeter behind this. So that passes around L5 vertebrae. As you can see, this L5 over here, L4. Then you have the L4 over here, and your L3 over here, L2 and L1 like this, right? So you have these vertebrae over here. Okay, so you have these planes, vertical and the horizontal planes, by which we divide the abdomen into 9 regions. Now, what are these 9 regions and why are they important? Both is important. Because see, if some patient comes to you with pain abdomen, then abdomen is not a very small area. Suppose a patient comes to you with let's say, pain in the teeth. You will ask, okay, which teeth? Because you have normally 32 teeth. Patient will tell you, okay, this teeth or that teeth. Just an example. The patient is coming to you with pain abdomen. A pain abdomen can have a multiple causes depending on which region and what is the site, what is the origin in relation to the food, and so many history techniques over there. But just telling you the site of the pain, you can have some rough diagnosis because if you know what structures lie deep to this area, right? You can have some rough diagnosis. That is why it is divided into 9 regions. Now, what are those 9 regions? Here we can see we have this epigastric region over here. What is the region? Epigastric, right? So if you go from top to bottom, we have this epigastric region, and around umbilicus, we have this umbilical region. And below this transtubercle vein, over here, we have the hypogastric region. So you have this epigastric, umbilicus, and the hypogastric region in the center. Now, if patient comes to you with pain in epigastric region, what is the organ over here? Rough idea I'm giving you on a clinical standpoint, what you normally see in clinics. At the epigastric region, no, normally gastritis patients will come. Normally. Okay, peptic ulcer, gastric ulcer, these patients come gastritis. Rare causes patient might come with some liver problem or even some heart attack also, but normally it is gastritis. Around umbilicus, it is basically gastroenteritis or small intestine, those issues, right? Or appendicitis, as I discussed earlier on. Appendicitis, in these pains are basically started from around umbilicus. Around the hypogastric, normally you have the pelvic organs pain, right? In females, normally the uterus and all that pain goes to hypogastric. So different regions have normally different etiologies of pain. Then on the right and left side, we have this hypochondriac region. What region? Hypochondriac. Now, some of you in the beginning might think, okay, sir, what is hypochondria? Such a complicated word. Okay. This epigastric and hypogastric, I hope it is simple to understand. Umbilicus is the umbilicus region. Epi means above. Okay, above. So upper part of the gut or upper part of the abdomen, we say epigastric. Epi means above. Hypo means below. So lower part of the abdomen, we can call it as hypogastric. Now, what is this right and left hypochondria? Now, this chondric means the word means over here is the cartilage. Now you can see this whole costal cartilage or this whole costal margin over here. So the region which is deep to this is known as hypochondria. Hypo means basically below or beneath it. So right and left hypochondria. And the sides of the umbilicus region, we have the lumbar region. We have which region? Lumbar, because area of the lumbar vertebrae is L3, L4, L5. So we call it as a lumbar region. And on the sides of the hypogastric, as we have this iliac fossa over here, so we call it as iliac fossa, right and left iliac fossa. Okay. Again, sir, what is the use of naming all of this? Different organs. Now you have to understand one thing, that till the time you are seeing all of these costal or ribs and costal cartilage, don't think that the thorax is over there, or wherever you have the rib cage, the thorax is up till the rib cage. No, it is not like that. Because diaphragm is not horizontally aligned. Right? Diaphragm is a J-shaped structure. So here, normally we have the organ like liver over here. So if a patient comes to a pain around the right hypochondriac or going to the epigastric region, it might be a pain of the liver, it might be a pain of the gallbladder. Similarly, on the left side, left hypochondriac, we have the mainly organs like spleen over here. So problem could be of the spleen. I am telling you the most commons. Now come to the lumbar region. What is this organ over here? Organs over here are basically the main clinical important are basically our kidneys, both right and left kidney. But as kidneys are present on the posterior aspect, those kidneys are not related to the gut directly. Therefore, the pain of the kidneys will start from the flank region, right, on the sides, not in front. Okay. Coming to the iliac fossa region, right iliac fossa, already we discussed that we have the most common, I'm talking about the appendix over here. Okay, so we have the appendix over here. And on the left iliac fossa, left inguinal region, okay, we have the sigmoid colon over here. Basically, diverticulitis like cases can arise from, or there can be ureter problems, ureteric colic, stones in ureter. There can be so many things, but common things. This is the reason why they took 2 horizontal lines and 2 vertical lines and divided the abdomen into 9 regions because of different etiologies. So next time any person comes to you with a pain in any part of the abdomen, you have to look closely at what is the particular region. That will give you a rough idea. right? This is the clinical aspect, well, which you can write a lot of it, right? Okay, so now these are all the things that addition or transpyloric plane, it passes between this and this structure. Anteriorly, it is at the tip of ninth costal cartilage. That is very important. Posteriorly, at the L1 lower border, as I already told you, organs present in this plane. So this actually transpyloric plane is very important because there are a lot of structures which are along this plane. So if a patient is lying down, I suppose in your viva, okay, now your in vivas, you have this body lying down where you have to mark very important regions over there. Okay, surface anatomy, what we normally call. And if someone asks you, okay, mark the transpyloric plane on the cadaver, how will you mark? Basically, you have to look at the rib cage, count the ribs, and look at the ninth. The lower one is the 10th, lowest one. Above it, you have the ninth rib. At the tip of it, ninth costal cartilage, you have the rough area where you have the transpyloric plane. So transpyloric plane is present where? At the tip of the ninth costal cartilage. And at this level, normally what we have the pylorus of the stomach. Then we also have the duodenum, we have the neck of pancreas, we have the hilum of the kidneys. In fact, let me add a couple of more structures over here. Apart from all of this, we also have the end of the spinal cord. The spinal cord in adults and at the lower L1. The spinal cord will end at the lower border or between L1 L2 junction. So terminal part of the spinal cord lies at a transpyloric plane. Okay, but there's neck of pancreas we have, very good. Your duodenum, we have pylorus stomach, we have hilum kidneys, yeah, and we have the terminal part of the spinal cord is what else we are going to get over there. Right, so this plane is important. Okay, let us move from ahead over here. Now, your regions we have already discussed. So which region has which organ is found in which region, that we can see. This image is very important, guys. All different color codings are given over here, right? And why it is so, because you can see over here, just see over here, the extent of the liver and understand it. The liver is not only lying in the right hypochondrial region, but patients normally of hepatitis or cholecystitis will come with a pain around the epigastric and the right hypochondrial. This is the area where the patients of cholecystitis or hepatitis will complain of pain, right? The different regions and different structures which are over there that you can go with it, right? It's quite important. Now, coming down to the peritoneum. Peritoneum, initially I discussed a bit of peritoneum already with you guys. What is peritoneum? It has these two layers. Okay, it has the two layers. Just a second. Right. So it is a large serous membrane lining the abdominal cavity. Fair enough. Serous membrane, similar as pleura and pericardium. Composed of an outer layer of fibrous, that is parietal layer, inner layer of mesothelial, that is a visceral layer. Okay, fluid secretes a serous fluid. It is a closed sac invaded by a number of viscera, similar to pleura and pericardium. Like when we discussed pleura and pericardium, we said, okay, it is like a balloon, okay, where if you put your fist inside, then that fist, imagine it is a viscera. Then the outer layer of the balloon becomes parietal, and the inner layer of the balloon, which is in touch with your hand, becomes a visceral layer. If your hand, imagine it to be a viscera. Similarly, that same thing happens in case of peritoneum as well. So peritoneum has an outer parietal, inner visceral layer, and we have the viscera which are suspended over here. Let's understand more of it. So bit of differences of parietal and visceral peritoneum, they can come or they can be asked in your vivas as well. Just be prepared of it. Okay, here we don't need any confusion. It's a basic thing. So parietal is lines the inner surface of the wall. Okay, it is derived from this embryology, somatopleuric layer of the lateral plate mesoderm. Okay, and blood supply, nerve supply is same as that of overlying a body. It is pain sensitive. Visceral is attached to the viscera. Embryology is different. It has splanchnopluric layer. Now, splanchnic means viscera, and somatic means the body wall. And blood supply is same as the viscera, and because autonomic, if the innervation, peritoneum evokes pain. Now, what will evoke pain in case of visceral peritoneum? It is basically the distension, okay, or ischemia. You have heard of heart attacks, ischemic myocardial infarction, angina pectoris. Even once you will read more, you will learn about mesenteric ischemia. What happens is, in case of viscera normally don't evoke pain. But when there's lack of blood supply to the viscera, then the viscera will cry of pain. That is when you will feel the pain. Okay. So in case of distension, okay, suppose you have this gas accumulating inside the gut, then they have pain. You have any obstruction in the gut, then the proximal part of the gut will obviously dilate. It will dilate, then there will be pain. So this distension. Okay, and this is ischemia. These things, they evoke pain in case of visceral peritoneum or viscera per se. Okay, this difference you should be very clear with it, right? Here, this is a lateral view. You have to understand this is the anterior aspect, that is the posterior aspect. Now here you see some of the organs. If I highlight with the, say, this green color, like with the stomach, we have the transverse colon. Okay, then we have with these two structures. Look at these two structures, stomach and transverse colon. They actually totally surrounded by the peritoneum, and that is why we call them as what? We call them as intraperitoneal. What do we call it them as? We call them as intraperitoneal, because they're totally surrounded by peritoneum. And they are hanged actually. You can see this transverse mesocolon over here. So some string is actually attached, but that string over here, this transverse mesocolon will be double layered. I will try to show you a diagram. Don't worry. On the other hand, now look at the structures. If I highlight the yellow color, like pancreas and duodenum, they actually present more posteriorly. So in these cases, what will happen if you imagine peritoneum with the black color, right? Then pancreas like this and duodenum like this. So they are also attached to the peritoneum, but only anteriorly. So they are like, stuck to one place. Pancreas and duodenum, they normally don't move here and there. But if you imagine the transverse colon, stomach, or let me tell you, jejunum or ileum, they are moving all the time. Okay, you can feel sometimes you eat something here and there, you feel the sound of peristalsis in your gut or not. Some like that sound, right? Those are the peristaltic waves. Even it is also said in examination that you took your stethoscope, always take your stethoscope and try to hear the peristaltic sounds. They will not come every second, obviously, but you keep your stethoscope on through the abdominal wall, wait for a few seconds, 15, 30, 40, even 1 minute, some peristaltic wave sound will come, slightly compress the abdominal wall and you will feel the sound, right? So these are structures like they are known as retroperitoneal. Okay, because they are present behind the peritoneum and they are not freely mobile. While the stomach, transverse colon, jejunum, ileum, they are freely mobile. Okay, this is one way to look at it. Now, folds of peritoneum. Before going to the folds of peritoneum, what we have discussed over here, I want to show it with the help of a diagram. Simple as that. Just be with me for a couple of minutes over here to understand the same thing, parietal visceral peritoneum. See, if we take a transverse section like this, TS, trans section like this, okay? If you take a transverse section, suppose this becomes a circle like this, okay? This is the ventral aspect, that is the dorsal aspect. We are taking a transverse section. Clear? Okay. Now see what happens is, suppose there is this organ over here, trans section, we have this ST dot, that is a stomach over here. Which organ is stomach? Okay. Now I'm making a couple of more organs. Say we have made this 2 kidneys over here. Okay, suppose this is the kidney, the K for kidneys. We're also making some blood vessel. Kidney is not this hollow, so we can make it like this. Let's make some blood vessel on the left side. Let us make this aorta. On the right side, let us make this is the IVC, and behind, let us also try to make this inside the vertebrae, the spinal cord. Just imagine like this. Now I'm showing you the peritoneum over here. So for peritoneum, let us choose a different color. Let us take the purple color, right? Suppose this is the peritoneum. Now, this peritoneum over here is close to the body wall, agree or not? So this will be which peritoneum? This will be our parietal peritoneum. I hope you agree. Then you can see this parietal peritoneum is covering the kidney and this aorta and IVC from front like this. So therefore, these organs, not just the kidney over here, but even this aorta over here, and imagine the IVC over here, imagine the spinal cord obviously inside the vertebrae, but okay, let me spinal cord and vertebrae, whatever it is. So they are all behind the parietal peritoneum. They are retroperitoneum. Now see what happens. Now I'm trying to change the color over here. So now this peritoneum comes over here like this. This parietal peritoneum. Now it comes forward like this. Okay, it comes forward like this. Now after coming forward like this, it then surrounds the stomach. It then surrounds the stomach. Okay, be with me. Now see what has happened. This peritoneum is similar. This is a simple, I just changed the colors. One is this purple, one is this sort of orangish, one is this sort of pinkish color, right? But they are in continuity. Now this peritoneum which is surrounding the stomach, this is the visceral peritoneum. I'm sure you understood. It is covering the viscera. Therefore, you say stomach is totally surrounded by the peritoneum. And this orangish color, which is actually connecting parietal to the visceral, this is what we can call it as a mesentery. Okay, it depends on which organ it is. This double-layered fold of peritoneum is joining. If it is joining the stomach, listen very carefully. If this double layer of peritoneum, let me write over here peritoneum. If this peritoneum or peritoneal fold, I'm writing two because it is double layered. This is mesentery or this peritoneum, which is double layered over here only in this area. If it is joining the stomach, we call it as normally omentum. If it is joining or it is connecting the small intestine, then we call it as mesentery. If it is connecting the colon, then we call it as mesocolon. If it is going to the body wall, then we call it as ligament. It is only the game of words. Only the name are changing. The things remains the same. What is the thing? It is just a double-layered fold of peritoneum. So now, sir, what is the use? The use over here, you might ask, sir, what is the use over here is, if you have a double-layered fold of peritoneum over here, disconnecting the stomach, so in place of mesentery, we can call it as omentum. Omentum or omenta. Fair enough. Now, what can happen? Suppose the food goes into stomach and stomach one needs to move. Stomach can move here and there slightly because it is connected by this omentum. Okay, so nothing will happen. Now, the thing, why do we have this double-layered fold of peritoneum? The reason is, you can see behind we have aorta, IVC, and spinal cord. So what will happen is, from aorta, the blood vessels will come and they will supply the stomach. Think. And from here, the blood vessels will go back. They don't go to IVC directly, but they will form the portal vein. From portal vein, they'll go to IVC. And you can see the spinal cord. So obviously, from the spinal cord, we can have the nerves also coming and innervating the stomach. So what is this double-layered fold? If I may highlight this color over here, mesentery, omentum, okay, mesocolon. What is this doing? Peritoneum double-layered fold. It is first of all making the organ mobile, freedom. Okay, freedom. You can go anywhere. You are doing the peristalsis, so free to move here and there. Second thing, it provides a passage for vessels, nerves, and lymphatics. Which three structures? Vessels, nerves, and also lymphatics. That is the beauty. You might think then, sir, okay, but is it so important? Yes, it is very important. Why? Because there are not 100 or 200 branches of vessel coming into the gut. Our gut is 6 to 7 meter long. There will be millions and trillions of vessels, and the gut is moving all the time. If you just leave the gut like this, there's no mesentery, then all the vessels will intermingle with themselves only, and would be very catastrophic. Because the vessels will actually go and cross each other, and they might, compressed by nerves or lymphatics, and vessels might compress each other also. Therefore, you need this safe path that is provided by this double-layered fold. This is what I wanted to discuss over here. I hope the point is clear. Now, if this concept is clear, then we can move forward. So what was the basic concept? Basic concept over here was recognizing what is parietal peritoneum, recognizing what is visceral peritoneum, recognizing what is this double-layered fold, and between these two, we have this peritoneal cavity, where you have the peritoneal fluid. Okay, this is a basic point. Now let us move forward. Folds of peritoneum. Okay, you can just go through it now. So degree and direction of mobility are governed by size and direction. So folds, obviously. Okay. Other organs are fixed and mobile. So I told you obviously what is retroperitoneum. The organs which are only anteriorly covered by the peritoneum, are retroperitoneum. Okay. Suppose let's imagine. How to give you an example? I hope the point is clear. But imagine if you place a hanky over your face, and your face becomes retroperitoneal. If your hanky, imagine it to be peritoneal. Okay. So examples of retroperitoneal. Some examples. Let me give you duodenum. Okay. Then we have the pancreas. Okay. Then you have the kidneys. Along with kidneys, you have the ureter. You can also add the adrenal gland over here. You can also go with the aortas, the IVC over here. You should also go with the ascending and descending colon over here. This is also retroperitoneal. So a lot of structures are retroperitoneal. Okay, some structure organs suspended. So apart from allowing mobility, the peritoneal fold provide pathways for very important point. For what? For the passage of vessels, nerves, and lymphatics. Peritoneal folds are given various names that we already discussed. Where to use mesocolon, where to use omenta, where to use ligament. That we already discussed, right? These are all the names. This diagram is basically for understanding. So you can see if it is connecting the small intestine, what are we calling it as? Mesentery. The moment it connects some other organ, say it is connecting the stomach over here, then we can call it as omentum. Okay, simple as that. So names are different, but their function remains the same. Okay, peritoneal cavity also I showed you, it is between the parietal and the visceral layer. So viscera which invaginate the peritoneal cavity completely fills potential spaces, separating a thin mesothelial cell that we have discussed. Now this peritoneal cavity, which you may remember we made that transection, and there's a huge peritoneal cavity. That is not actually huge, it is a thin layer of fluid over here. But sometimes fluid might accumulate over there on the patients, mainly of the liver cirrhosis or liver failure patients, that we call it as ascites. Okay, anasarca patients, generalized illness in the body, or hemoperitoneum. If blood may also connect of air. How can air be inside the peritoneum? Think about it. Bleeding can be there, so blood can be there, but how can the air be inside the peritoneal cavity? Not inside the gut. Gut already has air. How can the air from the gut, that is composed the small intestine, come into the peritoneum when there is a perforation of the gut? This new peritoneum will only happen when there's perforation, and it is a very serious consequence. Thus, the content of the gut, which is inside the gut, that is not a very good content to be present in the peritoneal cavity. And then when it comes into peritoneal cavity, then it is a emergency situation. Patient normally rushes to emergency at that time. Okay. So now the peritoneal cavity we have seen. What is the peritoneal cavity? But it is divided into two parts. One is known as greater sac, larger part, and one is known as the lesser sac. This lesser sac is also known as omental bursa. It's written over here. Let me write it down. Also, what is this? It is very simple to understand. The general peritoneal cavity, which is between the parietal and visceral layer, is greater sac. But there is a very small cavity which is present behind the stomach. Present behind the stomach, that is known as lesser sac. Then you might ask why that happens. Actually, that's due to embryology, due to different rotation of the gut. In this image, let me show you the lesser sac over here. This is again a sagittal view which we are looking, and therefore this is the anterior side, that is the posterior side. This over here is the stomach. The small cavity behind the stomach, that is the lesser sac, and this whole other cavity over here, this all will be the greater sac. This all will be the greater sac. And what actually happens is that due to the attachment of this transverse mesocolon, where is transverse mesocolon? Can you see the transverse colon over here? And this would be the transverse mesocolon, right? Automatically connecting the transverse colon to posterior, this would be the transverse mesocolon. Due to the attachment of the transverse mesocolon, this greater sac is divided into a supracholic compartment, as you can see over here. Supracholic means above the colon, transverse colon, and this will be the infracholic compartment below the transverse. Should know some names, but both of these are sort of continuous to each other. Even the lesser sac is also continuous to the greater sac via this epiploic foramen that we'll discuss. Okay, I'm again repeating. We have this whole peritoneal cavity, but due to the different rotations during embryology, there occurs a small space behind the stomach, and that is known as the lesser sac. It's quite important, but it's not easy to reach the lesser sac. And if some blood or fluid starts to accumulate over here, then you have to obviously be knowledgeable enough or be equipped enough to reach that area and to drain that fluid. And the other cavity, general cavity, is the greater sac over here, divided into supra and infracholic compartment. That is what is being discussed over here. These two sacs are communicating through epiploic foramen of Winslow or opening into the lesser sac, as we have shown over here, right? Epiploic foramen, also known as foramen of Winslow. Let us see the foramen of Winslow in this image. Now, look at this image, beautiful image over here. I hope some of you have might gone to the dissection halls and done the dissection, or at least must have seen the dissection. What actually happens is once you open up the abdominal wall, I'm telling you a very practical way, you don't see stomach at all. The stomach is covered by liver over here. Liver is a huge organ. It actually covers the liver. So what you have to do is you have to retract the liver to see the stomach. Once you retract the liver, then there is some communication between the liver and stomach, and that is known as lesser omentum. I told you no omentum, lesser omentum. The space behind the stomach will be what? The space behind the stomach will be the lesser sac, and this whole space which is in front of your skin will be the greater sac. And connecting the lesser and greater sac is the foramen of Winslow. So how to locate this? How to locate this is, again, if you retract the liver, there's this ligamentous attachment between, or peritoneal attachment between the stomach and the liver. This is the lesser omentum over here. Which omentum? Lesser omentum. Now, if you go to this right margin of lesser omentum over here, this is the right margin of lesser omentum, then there is a space by which you can pass even your finger. It's a big space over here. That is known as foramen of Winslow or epiploic foramen. You can actually pass your fingers over here. That is foramen of Winslow. What it is doing, it is connecting the greater sac, which is outside or in front of the liver, to the lesser sac, which is behind the stomach. This is the foramen of Winslow. Questions have come a lot in asking the boundaries of the foramen of Winslow. Boundaries, let me write over here. This foramen of Winslow boundaries are. Okay, let us see. Superiorly, what you can see the liver and mainly the caudate part of liver. Inferiorly, what you see, inferior boundary of the foramen of Winslow is not the stomach, it is this duodenum part. So we have this D1, first part duodenum. Okay. Anteriorly, what you see is this, you have this three structures in the right margin of lesser omentum. These are portal triad, P dot triad. These are the boundaries of epiploic foramen of Winslow. And posterior boundary, what you are not able to see over here, but posterior you have the inferior vena cava and vertebrae is around T12. Remember these boundaries of epiploic foramen of Winslow. These are very important. Okay, this topic is quite important, right? Okay, now let's move forward. The function of peritoneum. You can elaborate as much you want, but basics will remain the basics. So movement of viscera, as I already told you, we meant to move the viscera. Visceral cells, protection of viscera also has phagocytic cells. And do remember that the greater omentum is known as policeman of it. Now see, practically, this is suppose the costal margin, that is the inguinal area, this is the umbilicus. Now imagine some infection is developing in this area, this yellow colored area, some infection is developing. If something does not come and hold it over here, then slowly within hours, this infection will spread to the entire abdominal cavity. And what started as a small issue in some hours, in 6 or 12 hours, will be a very big issue. So as soon as the problem starts, what happens is the greater omentum will come and cover this area. Okay. So it will, this is the reason why it is known as the policeman of abdomen. What the greater omentum? What is a greater omentum? Omentum, remember, is again a peritoneal fold, but connecting stomach to other regions. That will see greater because the larger, lesser omentum because it is smaller in size, simple as that. Okay. So one function is this, second is this, absorption dialysis. Very good. So these are all practical uses. Okay, even peritoneal root over here, then peritoneal dialysis is being given. Just go through that. These are functions basically. And then your healing power adhesions, storage of fat also, yes. The people who are very obese, you open if you open the body, if you do a laparotomy or after death, if you are in a DH, you see a lot of fat in the mesentery or the peritoneal fold of the concerned person. And let me tell you, around how many years must have gone by, around 6-7 years back, the mesentery is actually now been made as a different organ altogether. Initially, 10 years back, we used to just read mesentery as a part of the gut only. It is a part of the gut, but its functions are so much. It is regarded as a separate organ, medically, I'm telling you, right? Okay. Now, coming to the development of the gut. Now, gut we all know is divided into 3 parts. Again, basics is what we are going to touch today. Foregut, midgut, hindgut. You should know from where to where is which gut. Foregut is up till the middle of this second part, up till D2, till the middle of D2, where you have this opening of the pancreatic ducts. Midgut is up till your proximal 2/3 of transverse colon, and hindgut is up till the rectum. Then you have the anal cavity. And why we divided these 3 areas? The reason is their blood supply and nerve supply, it starts to change. For example, blood supply over here is these 3 arteries given over here. So all these 3 arteries are coming directly from the abdominal aorta, but 3 arteries are different. Secondly, the nerve supply also changes. Nerve supplies, if we talk of the foregut, midgut, hindgut, then if I say parasympathetic over here, then parasympathetic over here for foregut and midgut is vagus nerve. Axis is vagus nerve. For hindgut, it is S2, S3, S4. right? And also, if we talk of sympathetic, then that will also change. It will be greater splanchnic nerve, okay, then lesser splanchnic nerve, then lumbar splanchnic nerve. All these changes. So embryologically, it is not something division which some doctors might have said in a meeting and then okay discuss, okay, gut is so long, let us divide it. It is not like that. The divisions of the gut is based on the embryology and the development. It's not randomly divided like this. There's a meaning behind everything. Let's understand this point. Okay. Okay. No. No. So yeah. Ventral mesentery has mesogastrium, dorsal mesogastrium, right? So we are coming to another important part of the understanding over here. You see some diagrams over here. Don't worry. Don't worry. Let me take this some empty space over here or upward if we can get a bit of a little bit. Yeah, that is also good. Now see what happens is we said that we have three parts of gut: the foregut, the midgut, and the hind. Fair enough, right? In that previous image which I drew, this transverse section, when we do the transverse section, we made that this was the parietal peritoneum, if you remember. Okay. Then we changed the color. We said this is the mesentery, or you can call it as any mesocolon, whatever it is. And finally, we said, okay, that this is the visceral peritoneum, right? In the diagram, we also said that this is the ventral and dorsal aspect. We said that this double-layered fold of peritoneum is connecting the viscera over here to the dorsal body wall. Dorsal body wall, right? So it is connecting viscera to the dorsum. No? The reason which I gave you was logical, that we have the aorta, the nerve supply, the lymphatics in the posterior aspect only. So there will be a dorsal double-layered fold of peritoneum. Agreed, done. Now, there's slight change. The change over here is this phenomena, that is when we say that the dorsal peritoneal fold or dorsal peritoneum, I'm writing a broader word as peritoneum. This dorsal peritoneum is present where in case of midgut and hindgut, and also the foregut, foremid and hind, all the three. But it is only the foregut. It is only the foregut which will also have what? Ventral peritoneal fold, which is known as ventral mesogastrium. Then you might argue that, sir, what is the use of connecting anterior? The anterior is nothing. There's no aorta, no IVC in front of the abdominal wall. Why the nature connected it? The nature connected it anteriorly. Let me give you the reasoning also here. Because the reasoning is important. That might be asked in the Bible. The foregut has ventral mesogastrium. The reason is that during embryology, the nutrition was coming from the umbilical cord, where we had the left umbilical vein that was carrying all the food from the mother placenta. That was present anteriorly. So that remains through the foregut, because that vessel passes through the foregut on left umbilical vein and through the liver and all. Therefore, its remnant remains in adulthood. It won't vanish, but it will disintegrate, right? But it won't vanish. No, there's some go like this. There are some small vessels which are running still. Therefore, it remains over there. That is the whole point. Okay, so foregut will have both front mesentery and dorsal mesentery, while midgut and hindgut will only have dorsal peritoneal fold or dorsal mesentery. Let's say it like this, right? I hope the point is clear. Now, let us come to that area which we are discussing over. Okay. So ventral mesentery of the foregut, I just told you why we have ventral mesentery of foregut. It's called ventral mesogastrium, and dorsal mesentery is known as, why we are using different word. Gastrium means stomach. That might have provoked it to use a different. Fine. Now, see, diagrams are over here very beautiful. This is again a sagittal view to show you anterior, posterior. Okay. And this is, imagine the gut over here. That is a part of stomach over here. So all of this, which is connecting stomach to the posterior dorsal body wall, is regarded as dorsal mesogastrium. And in front is known as what? It is known as ventral mesogastrium. Simple. Now see what they are showing over here, that there's some septum transversum coming. What is that septum transversum? Nothing. It is just a part of mesoderm. Remember it for now like this, but we study little in embryology. It's a cranial most part of the lateral plate mesoderm. It's a mesoderm. This septum transversum slowly will give rise to an organ known as liver. So over here in this area, liver is going to come slowly. When the liver will come over here, then this organ liver is a huge organ we all have seen. This organ is going to divide the ventral mesogastrium into a more anterior part and a bit of more posterior part. It is a ventral mesogastrium only, but there's an organ coming in between, that is the liver. Let us see over here what happens. So again, they are showing how the stomach is being developed over here. Okay, yes, showing the greater curvature and the lesser curvature. And here, this is area which is going to form the liver. So this whole, if we show you with this red color, ventral mesogastrium is this area. Now the peritoneum between the liver and the stomach, this is what is known as the lesser omentum, which we showed while discussing the epiploic foramen. And this part which is in between liver and the body wall, this is your falciform ligament. This is the falciform ligament. And liver itself is intraperitoneal, so there are a lot of ligaments covering the liver. So falciform ligament, lesser omentum, and the ligaments of liver, this is red color, imagine, they are all derivatives of ventral mesogastrium. So ventral mesogastrium gives rise to what? If we write separately over here, that ventral mesogastrium gives rise to what? One by one, if we go, then it gives rise to lesser omentum. Okay. Then the ligaments of liver, you should know some names like coronary ligaments, triangular ligaments, all these are ligaments of liver. And then finally, we have the falciform ligament, which is going from liver to the anterior abdominal. These are derivatives of ventral mesogastrium. Dorsal mesogastrium, imagine this over here. This is the dorsal mesogastrium. It is facing the greater curvature. So what it gives rise to, basically the greater omentum, which is also known as a policeman of abdomen. Then on the left side of stomach, we have organs like spleen. So it also gives rise to gastrosplenic ligament. Even gastrophrenic ligament, all that comes on the left side. These are all derivatives. This is what you should know. And all the derivatives are given over here. What is the fate of dorsal mesogastrium? It is on the left side. So it gives rise to gastrosplenic. Let me just highlight over here. Okay, greater omentum obviously to begin with. Okay, then you have the gastrosplenic ligament, you have the linorenal. Linorenal means between the spleen and the kidney. Okay, and gastrophrenic ligament. All these are derivatives of dorsal mesogastrium. Right, they are left to the stomach. Okay, some anomalies are given over here. Fate of ventral mesogastrium, as we discussed, is the lesser omentum, and others also I already told you. And there are some anomalies, some anomalies over here are written. Just can go through it. Some anomalies of the development of the stomach are given. Pyloric stenosis, we have thoracic hourglass, transposition of the stomach, 3-4 anomalies, and diagrams are over here. Okay. Okay, now let us finally come to this one more question over here, that about the greater omentum. Now see, let me just try to show you over here what actually happens. So we have this organ that is the stomach over here, right? So we have this esophagus coming down, the lesser curvature and the greater curvature, and the duodenum going down. What happens now is that this coming from the lesser curvature going to the liver is which omentum? Lesser omentum. This green color which I'm trying to make is the greater omentum. Now it is quite huge. It was known as what? Policeman. So it can go down and cover the entire intestine. But when it goes down at the lower border, what happens is that it curves back. It curves back from here. Okay, and it then again will go behind this green part. This all is greater omentum. So there are 2 layers coming down and 2 layers going back. Total how many layers? Total we will have over here 4 layers. 4 layers of greater omentum. Then what's going to happen is that this will go to which structure? This will go to transverse colon, and then it is going to wrap the transverse colon and then form the transverse mesocolon. Then it is going to form the transverse mesocolon. So there are 4 layers of greater omentum. Try to understand. They are coming from the stomach down. They are covering the entire intestine, and then those 2 layers are going to go back. As they go back, they don't go directly to the stomach because that is embryology. they go to the transverse colon. And from transverse colon, they will wrap the transverse colon. Imagine transverse colon is like this over here. This is the transverse colon. And then they will go behind as a transverse mesocolon, which will attach where? It will attach basically to organs like pancreas. This is the whole point over here. Let me show you it with a diagram. Okay, about there. There were a few diagrams which you will see and understand this. Look at this one. Now, look at the stomach. This is the first two layer. I'm making this red arrows. Can you see? These are the greater omentum, first two layers. At the lower point as they reach, then they turn back. These are the posterior two layers of the greater omentum. Now they reach where? They reach the transverse colon, TC over here. And from here, they are going where? They are forming the transverse mesocolon, as I wrote over here, and they lie in front of which organ? Pancreas. Okay, trace it. This was the sagittal section. This was the sagittal section. I hope the point is clear. It's very important to understand. Okay. So, greater omentum, you understood that it folds down, right? Hangs down from the greater curvature, made up of 4 layers. You have to understand, and examiner will ask you. But these 4 layers you can't see. They actually all fuse together. They form a thin membrane, and there are various vessels and nerves which are traversing that. Anterior 2 layers, posterior 2 layers, contents are what is important. Because tomorrow, when you're doing in an internship or if you join surgery, you have to open the greater omentum. You should know what is in store for you. You have the gastroepithelial vessels which are inside the greater omentum. They are present inside the greater omentum, and it is also often related with fat. You can see this is the yellow color which they are making, right? You should know this. Functions are again similar for the peritoneum function, because greater omentum, lesser omentum is nothing. It is just double layered fold of peritoneum. Greater omentum, it is double, that is 4 layer. But actually all of it is going to fuse. Okay, so when you say vessels are there, you have to slightly dissect out, and then you are going to see the vessels. Okay. Similarly, lesser omentum was going from lesser curvature of stomach to the liver. Okay, so it is between stomach and liver, and therefore also known as hepatogastric and hepatoduodenal. Now there is a small catch. The catch over here is that when we say the lesser omentum, okay, then we make like this, no, that okay, this is the lesser omentum going like this is fine. But there's also a small amount which is coming from the first part of duodenum. These both will combine to form the lesser omentum. So you have this hepatogastric HG going from liver to the stomach, and you have this HD going from liver to the duodenum. They both will combine to form the allo lesser omentum. That is what we're discussing over here. And we have already discussed the epiploic foramen. And I already told you even the boundaries of epiploic foramen. Look at here, the similar thing. Let me just highlight over here differently. Okay. So this is, can you see the hepatogastric over here? This is the hepatogastric yellow color. Okay. This is still the stomach. And then comes what? Comes the hepatoduodenal part. This is the hepatoduodenal part. And they both will combine to form what? Lesser omentum. And can you see this foramen of Winslow epiploic foramen? This is behind the right margin of this whole lesser omentum. So this whole lesser omentum, this yellow and green color, and if I show with the say red color over here, this is the right margin of lesser omentum, and that is the epiploic foramen. Okay, that is the epiploic foramen, and boundaries I already told you what are the boundaries of epiploic foramen. That is very important. Okay, lesser omentum, they are giving some attachments. Okay, inferiorly attached to the stomach and to the duodenum, and then reaches the liver in the form of inverted J shape, inverted L shape. So this is how it is. The attachment on the liver looks like this. Attachment on the liver. Okay, this is attachment of on the liver. This is the whole lesser omentum. Contents of lesser omentum is not just a couple of vessels, but very important portal triad. Well, that is lying in the right margin. That is lying in the right margin of the lesser omentum, the boundary of the epiploic foramen. Okay, the contents will be like this along with the right and left gastric vessels. This thing we should be aware, right? Now around mesentery and all, mesentery we have discussed, but okay, in the next lecture we'll just go through the mesentery. Today I hope this much knowledge is sufficient. Again, as I said in the beginning, it was basically conceptual. If you understood the concepts, then abdomen is nothing more. I mean, all the other areas you will only talk of the organs, their coverings, their blood supply, the relations, that's it. Once you understood the basic concept of peritoneum, because that might look confusing in the beginning. But I hope I have helped you over here in understanding. Go again through it if you want to, and see you in the next lecture. Till then, bye-bye and all the best. Thank you.